So this meeting is just for us to exchange our ideas about what is happening now globally, the pandemic. I'm not going to waste much time introducing both of our key speakers. If you have questions, please type it on the chat box. The first to go is Dr. Raj, correct? Yes. Okay. So Dr. Raj is well known to all of us. He is the chairman of Pallium India. He's quite familiar with managing palliative care, the holistic care during times of urgent situations like what we are seeing now. So the title of his talk is how to take care of patients with palliative care during a pandemic. Over to you, Dr. Raj.
Aju, would you mind sharing that screen and having my presentation on the screen? Dear friends, almost everybody here seems to be a friend for a long time. Maybe there are a few people whom I do not know personally, but thank you all for being here.
Can you
everybody,
see it?
Yes,
is it clear?
Yes. Like everybody else on this planet, I am also new to this new challenge that the world is facing. And scary as it may be, it will be good to be prepared for what is going to face us tomorrow, maybe next week, or maybe next month. Aju, can you give me the next slide? Having gone through several meetings about the COVID issue in several fora, one thing that seems to be very clear is that apart from the palliative care people, almost nobody wants to talk about people who cannot get cured. Practically nobody wants to talk about end-of-life care. If you talk about it, they nod and then quickly pass on to more pleasant things. That means pretty much soon we are going to face this, and then we are not going to like the situation because nobody will know what exactly to do. Almost everybody now is thinking of putting every patient with pneumonia on a ventilator. The focus of all the preparation is on prevention and treatment. And again, not only end-of-life care, any element of suffering is not really discussed much, except a passing mention of the distress of isolation among some people. This attitude, as well as a varying array of different attitudes from among the common public, officials, bureaucrats, everybody, is this problem of not being prepared to face the eventuality that's awaiting us tomorrow. The public fear is varying from a few people in total denial, saying everything is going to be okay, to absolute panic, unreasonable panics. And a lockdown which happened in Kerala day before yesterday and 2 days back and all over the country yesterday has certainly challenged delivery of care. While it may slow down the spread of the virus, it is certainly challenging delivery of care, and almost all corona treatment centers are devoid of palliative care personnel at the moment. There are exceptions, of course, like Kochi. Aju, next one, please. The fear of course, is practically all over the world about the unknown. And then immediately most people are worried, will I get the disease and will my loved ones get the disease? Uh, there is not enough education at the moment, and that is the key for preventing these irrational fears. At the same time, being able to take the positive from the fear and to be prepared. Uh, be in the palliative care fraternity has to take on the responsibility of starting education about what's going to happen, the elements of suffering, about end of life care also. Uh, one of the problems that all healthcare personnel, many healthcare personnel face, especially women in our male dominated Indian society, is the pressure from the family. Don't go to work, report sick, and that kind of pressure. But I'm so gratified to find that almost every member of the team overcomes this challenge. And the lockdown during the last 2 days has certainly caused a huge problem in transportation. We today managed by getting every vehicle out at 6 o'clock in the morning to go to various places and fetch the staff and volunteers. But not everybody will be able to do it. Access to medicine and supplies is already a problem, and it's going to be a much bigger problem. And almost every center is worried about even simple things like masks, leave alone all the personnel protection equipment that will be required tomorrow. Aju, next one, please. Another huge suffering. Okay, Kerala may be slightly better off because except in the hilly terrains, most areas will still have some kind of transportation. But all over the country, this well-known public health specialist, Dr. Jay Prakash, asked this question. I think he asked this question day before yesterday. Just take one example. 80,000 women deliver in a day all over the country. How will they access any healthcare? And that is just one example that he quoted. It's about all kinds of healthcare and access that's going to be challenging, except in the cities, particularly in the states outside. 2 or 3 states maybe will be slightly better off, like Himachal Pradesh, maybe Tamil Nadu and Kerala, but majority of states will have this huge problem. Next, please. Aju, next slide, please. Okay, sorry. I think there was one before this. Yeah. So what we now do not know is what exactly will be the nature of the suffering for the people in the villages, particularly for the poor, about whom not many people are giving much thought to at the moment. Next, please. Particularly the people who are dependent on their daily living. They earn from day to day and eat. All of a sudden, there is no earning. How will that 35 to 45% of Indians live next week? And what will that do to the social fabric and the law and order situation? We even now do not exactly know what are the elements of suffering. In a discussion even yesterday, Moira Leng taught me that agitation is a common problem. Most of what I read had not discussed agitation much. We are going to see the horrendous effects of isolation, and imagine the plight of just in our state of Kerala, 170,000 elders living alone, single member households. They at least had somebody to talk to through the window so far. Now, how will they survive? So, every element is going to be a virtual unknown. Next, please. The few symptoms that we know of: cough, breathlessness, agitation. These are the visible parts of the suffering to the average healthcare professional. We in palliative care know that so much will be under the surface. And one of the things that we are concerned about is how relationships will work once a nuclear family is confined to a room or two rooms. Loneliness is a horrendous disease. It was already bad in our brave new world. That's going to be so much worse. I am not making that, I'm saying that as an ideal statement. These are things we can do something about. Next, please. One huge problem that I face is that everybody seems to be thinking that every patient with severe COVID will go on a ventilator. People are looking for more and more ventilators. And the fact remains that only a tiny minority of people who go on a ventilator, especially the elderly, will survive. Nevertheless, this is likely to be inflicted on them. Now, here is one thing that is absolutely necessary. Most Indian hospitals do not have ethics committees. They have, even if it's called ethics committee, usually it's only for research purpose. They are institutional review boards. Now, within a few weeks in India, we are likely to face the situation where the limited number of life support systems available will be challenged by the ethical question: to whom should we give it? Is it fair at all? Isn't it unethical to say that no, we will triage old people out? We will reserve it for children and young adults. Those are the most productive age. How will we tackle this issue? And one suggestion that we have put up to Kerala government is straight away give an instruction to institutions to form ethics committees so that these conflict between autonomy and distributive justice can be dealt with by an independent body instead of the intensivist who is in that room, challenged by this dilemma. Next, please. What we are going to create, we must create in the next few weeks, is a system for educating the intensive care doctors. There will be hardly any palliative care teams helping out there. I think they desperately need support for treating breathlessness. It will be a challenge to provide, to get people to get access to personal protection equipment and to get people to be able to use it. In Kerala particularly, 900, about 1,000 nurses go out on home visits from every primary health center, every government hospital. More than 300 non-government organizations go out on home visits. We all now will have to learn to minimize interaction with patients for their protection also, as well as ours, and manage more of patient care over the telephone. We have already started distributing whatever medicines they are on for at least a month and a half, and where necessary for 2 months. The supplies include food. In our unit, where we look after maybe like something like 1,500 to 1,800 unique patients at a time. We are providing food kits to 75 patients, around 75 patients. These are people who cannot possibly eat without that. Okay, we had started it a few days back. 2 months supply is being given to them. Catheters, spare urinary catheters are left there with the patient, so that if some healthcare worker can get there, the catheter will get changed where necessary. Uh, I am not here talking about the official helpline of the government, specifically with the purpose of giving attention to our patients in palliative care. Every palliative care unit will have to set up a telephone helpline service. We have not started it on 24 hours basis yet, but over the next couple of days, we hope to. Next, please. Now, we generally the government seems to have accepted this principle, this suggestion that some education on symptom control will be provided to the intensivists who are mainly managing intensive care units designated for COVID, but also for all the doctors who are manning isolation rooms for these patients. We will have to provide them this new learning that the fact that somebody is in respiratory failure doesn't immediately mean that they must go on a ventilator. The triage will be necessary. Artificial life support will be very inappropriate for many of them, and especially when it's the elderly person who has very little chance of surviving after a ventilation. Symptom control will have to be affected. The proposed scheme, simple scheme that is to be taught to the doctors is, if the person can swallow even antiemetic, we'll suggest that two medicines that are possible. Morphine in a dose of 2.5 milligrams 6 hourly is to be given to the patient. There is a question whether this is appropriate for everybody. We will simply have to teach the doctors. If the breathlessness is significant for the patient, then this can be given. And of course, the laxative. And we will suggest that for, in this case, lorazepam sublingual may be an appropriate medicine. Whereas those who cannot swallow anything at all will go on the antiemetic and 1 milligram doses of subcutaneous morphine, and they will also be given a laxative, whatever measure that is, maybe rectal measure when necessary. And this will be supplemented by midazolam 1.5 milligrams subcutaneously as frequently as necessary. Now, this is the current proposal. The proposed thing, this is to be discussed between experts. The team in Kochi, many of who are available here, have been discussing new plans. So this is something that I'll put up before you, unless there are other plans already. We'll have to discuss this and make it operative as soon as possible. Next, please. Short of breathlessness. Sorry, next one, please. For cough, we would recommend to all the doctors manning COVID isolation wards, particularly, that they should have dextromethorphan to give to the patient. Dextromethorphan by itself is not easily available in this country. There are numerous preparations with all sorts of combinations, many of them totally inappropriate and unnecessary. If we cannot get dextromethorphan by itself, the one with mucolytic plus dextromethorphan, that may be the most appropriate for the majority of patients. And if that turns out to be inadequate, patients will have to be treated with morphine for intractable cough. I'll remind everybody, this is only a suggested protocol for discussion between everybody and decision. And a reminder, this is not for palliative care people. This is specifically a regime for palliative care naive doctors and nurses who are actually treating people with COVID. Next, please. And for agitation. Next, please. No, there's one before this. For agitation. Again, the suggestion is to start with haloperidol, 1 milligram. The suggestion is that this should be repeated hourly, up to 5 milligrams if necessary. And if the patient is not resting, then add midazolam 1 milligram subcutaneously every 10 minutes till the agitation is controlled. This may require a very variable dose of midazolam. I have not given any recommendation here about how this is to be followed up. That is something that we'll have to discuss further and decide. In palliative care, we all give up to 20 milligrams of haloperidol in a day for agitation if necessary. But I'm not sure how appropriate it will be to make that suggestion to palliative care naive doctors. I'll stop here and hope that despite the initial loss of time because of the hackers, we would still have some time to discuss this further. Thank you very much.
Thank you, Dr. Raj. Thank you for that insightful talk. I think we all need to be prepared for what's coming. I'd like to invite Dr. Perlman, Stanley Perlman. He is a professor of microbiology pediatrics at the University of Iowa. He's considered a world-renowned expert in coronaviruses, and he's exclusively studying on SARS and MERS. In fact, I came to know about him when he actually wrote the editorial on January 25th, when several of us didn't even know anything about the coronavirus that has attacked Wuhan. And I was just rereading the editorial that he wrote. A lot of things have changed, even from what he has wrote. So a lot of things, I'm sure he had. So the title of his talk is, what do we know and what do we not know? I think it's our honor to have Dr. Perlman with us to give us an understanding of what's there in front of us. And I'm sure he will be able to answer some questions as well. Over to you, sir.
Please share the screen.
Yes, I'm going to share it, I think. Whoops. Are you doing this, Aju, or do you want me to?
Let's have
it's totally up to you. Would you like to do it yourself?
Because I'm finding when I share.
Stan, let's just have Aju do it. That's fine.
Oh, okay. No, he's done it. That's good.
Is that working?
Yep, good.
Okay. Okay, so as you said, I'm going to be talking about this new coronavirus epidemic, COVID-19, and try to cover some of the things we know and don't know, and also where we are coming from, because we actually know a lot about coronaviruses over the 18 years since SARS coronavirus first appeared in China. So here's some of the questions that I hope to answer over the next bits of time. I won't explicitly answer them, but these are questions that I'm often asked. One is, will COVID-19 spread less in warm weather? And what do you think of the combination of hydroxychloroquine and azithromycin? Influenza virus causes more illness and death, so why do we care about COVID-19? The mortality rate is low. What is the big deal? Can the virus spread asymptomatically? How is it transmitted? And why is it so hard to control? They say the coronavirus, is there only one? Was the cruise ship quarantine a good idea? I can answer that right now and say no, it was a bad idea because it ended up being an incubator for virus spreading among people on the boat. Why did SARS disappear and this virus is pandemic? How long will a vaccine take? Do we have any drugs to treat this? Should I avoid NSAIDs like ibuprofen? Should I stop my high blood pressure drugs? So before all this began, we've known about coronaviruses since the 1940s. These were mostly animal coronaviruses, but in humans, we knew about these two of these coronaviruses, 229E, the first one, and OC43, the last one. They have been around for at least since the 1950s and 60s. Trials were done with them, and one of these trials is important for what we're thinking about now. Volunteers were taken who actually had antibodies to 229E, so had seen the infection. They could be reinfected with 229E and then got the common cold. So this told us something about the immunity to these viruses. And these coronaviruses caused up to 15 to 30% of human colds. And as I just noted, there was no durable immunity. There were frequent cycles of reinfection. And most people who got these infections had upper respiratory tract disease. Some immunocompromised people or the elderly developed more severe lower respiratory tract disease, which is a similar story to what we're hearing now. No vaccines or antiviral therapies are licensed or in use. So in 2003, SARS coronavirus was recognized. And as a coronavirologist, this was an interesting experience because after it was recognized, there were several reports about how coronaviruses had been the backwaters of virology, and we came out of the backwaters. For SARS coronavirus, there's 8,000 cases. There was 10% mortality. Just to put this in context, of the 8,000 cases represented about as many new HIV cases in the world as occurred in about 12 to 16 hours. So in terms of absolute numbers, this was not great, but in terms of affecting specific regions of the world, like China and Hong Kong and Canada, where one person brought in a virus that spread to 250 or so people in Canada, in Toronto in Canada, they had huge social and economic implications. We know that the SARS coronavirus actually spread from bats, which is again a common theme, to animals like civet cats and raccoon dogs. I think I'll show that. Let's wait a second here. Yes, these are these critters. So the palm civet cat is one of the intermediaries. This is not a cat, actually. The raccoon dog, it is a dog. And so we learned about these animals in 2003, and they were probably the intermediates in between the bat and humans. And then after this occurred, SARS coronavirus, or SARS, was contained by quarantining. And the reason for that, I'll go into a little more detail, but the main reason is because it's a lower respiratory tract infection. So that meant people were really only contagious after they developed symptoms. And so because of that, you could identify someone who was ill, you could quarantine them. And that's the reason that the epidemic was contained. Really, it was first cases were November 2002. By July 2003, it was really completely contained. And then we saw the MERS coronavirus rise in 2012. This one is a different kind of virus. There's only 25 cases since 2012, which is about 2 cases a week, but there's about 35% mortality. This is a disease that's not terribly contagious, but it is within hospitals, and that's where most of the deaths occurred. Not where most of the deaths occurred, but where most of the transmission occurred. And now that we're getting better at controlling this virus, we know that most cases now seem to be primary, which means arising in the community, probably from camels, because camels are infected with this virus. And what's really a curiosity is camels all around the world are infected, from Africa to Asia to the Middle East. And only in Saudi Arabia is the virus going from camels to people. We don't really understand why. And why didn't it happen until 2012? We know this virus was in camels at least since 1983. And then, of course, since then, we've had this new coronavirus, SARS coronavirus 2, is now it's officially called. This slide is out of date. It was, I don't know how many weeks ago, not that many, 75,000 cases. Now the number is several hundred thousand. Mortality greater than 2%. We don't know if it's 0.5% or 2% or 3%. In places like China, it was between 3 and 4%. In Italy, it seems to me it's much higher, but I think they're not doing testing very widely, just like we are not in the United States nor in India. And so the mortality may well be a lot lower than these numbers, because I think there's going to be more and more people who have mild disease and are never picked up by the healthcare system. And now it was originally in 29 countries. That's wrong. It's almost in every country in the world now. So just to go back to the severe acute respiratory syndrome in SARS, one of the big deals for this was that fear played a major role. So that's something to think about, because that's what we're dealing with as well, as Raj pointed out. So the SARS emerged in China in 2002, and I'm going over this just in one slide because it has so much similarities to SARS-CoV-2 infections. It arose in wet markets. We think SARS-CoV-2 also arose in wet markets. Wet markets where live animals are sold. These are most usually selling animals like chickens and other animals that are consumed for food. In China, in addition, there were some exotic animals that were sold that are not sold elsewhere. And this is no longer allowed. And in fact, even before this epidemic began, China had outlawed the selling of some of these animals. And these animals sometimes were imported, and they sometimes were sick. And so it's possible that they are part of the conduit of how virus went from bats, where we know this virus first initiated, to humans. We don't have a virus that's so close enough to the human one that we know for sure what the source is. We found that it was the SARS virus was caused by a new coronavirus, and as I mentioned, it was really a bat virus, and it crossed from the wet markets to humans many times. The epidemic that was most well known is one that crossed from China. Well, a handler in the wet market, someone taking care of selling the animals, became ill. I think a lot of them did. 35% of handlers are actually positive for the virus. But this particular one was seen by a physician who was very susceptible to the infection. Being very susceptible to the infection, what he did is, instead of going home and resting in bed, he decided to go to a hotel in Hong Kong for his nephew's wedding. And he was on the 9th floor. He became very, very ill on the floor, and I think actually he vomited and aerosolized sufficiently to infect everyone else on the floor. They all went home to their countries, and that's how the epidemic began. But the virus was continuing to cross from the wet market to other people in China, and so that's what explains the large number of cases actually occurring in China. So the Middle East respiratory syndrome, I think in the sake of time, I'm going to skip this and to go on to what do we know about protective immune responses in coronavirus infections. We know that for the non-SARS, non-MERS human coronavirus infections, protection is transient. So we did studies that show in MERS, antibody can be detected 6 months after infection, but not 2 years later. So particularly if the infection is mild, antibody seems to wane. And this may be very important for the present epidemic, because we're finding more and more people who have mild or asymptomatic disease. We don't know if they develop antibody. We don't know if they're protected against reinfection. This is, of course, a big issue. And of course, if we develop a vaccine, the same question comes up. Are these people protected for more than just a short period of time? We hope this virus will disappear in a year to two, but if it actually hangs around in human populations, and there's really no reason why it shouldn't, it's very well adapted, then we may need repeated vaccinations. We'll have to figure that out. We know from other studies that vaccines against coronaviruses in domestic and companion animals provided imperfect protection, and there were other problems. And ironically, the best vaccine is one that rose naturally. There was an infection of pigs that called transmissible gastroenteritis virus. This virus caused great lethality in young piglets. And it turns out that after a few years, a version of this arose that lost its ability to infect the gut and could only affect the respiratory tract. And what it did is it didn't kill animals anymore, but it got great immunity. So this TGEV, or transmissible gastroenteritis virus, completely disappeared. So this is a great model. It's one of the reasons I think that live attenuated vaccines, if we can figure out how to do one safely, is really the best way to confer immunity. And most vaccine efforts are focused on the antibody responses, but we think that T-cell responses, the other part of the immune system, is really equally important. So let's go on to COVID-19 and SARS-CoV-2, which is its etiologic agent. So The earlier slide talked about 29 countries. You can see that's a gross underestimate. Probably all the countries that don't have it haven't looked for it, rather than it really being absent from those countries. I think it's probably everywhere. And in the United States, as of a week ago, this is where the epicenters were, where the cases were found. It's now in 50 states. Every single state has some. You can see there's a little circle around Iowa City. It's just a little circle. It's over here, but it's still bigger than the rest of the state. And I think the majority of, not the majority, but a disproportionate numbers are in the Iowa City area. Last night we heard about one patient in Iowa dying. This is not a surprise because there's 125 cases, one person died. That's about that same 1% ratio that I mentioned earlier. So what do we know so far about this virus? The bats are the probable source. It's probably spread almost solely by droplets in contact, but we can't rule out that there may be some aerosolization, there may be fomite spread, there may be spread on surfaces. The virus can remain on surfaces, but whether it's actually ever transmitted from there, we don't know. The incubation period is 5 days, and we know that there's sustained human-to-human transmission everywhere. The period of communicability is considered to be 14 days, and the ability to transmit, or the R0 factor, is variable upon different settings. We learned from SARS and MERS in healthcare facilities, if proper precautions are not taken, then transmissibility is very high. So the R0 is very high, which is a measure of transmissibility. And R0 of 0 means that, R0 of 1 means that one person will infect one other person, and R0 of 3 or 4 means that a single person will infect 3 or 4 other people. So you can imagine if someone's infecting 3 or 4 other people, the spread is very rapid. The R0 for this disease is considered to be about 3. So this is a report of an asymptomatic infection resulting in symptomatic infection in contacts, and this turned out to be incorrect because this, even though this report appeared on January 30th, it was retracted very soon thereafter because it was realized that the person who went back to China, and this was a person visiting China in Germany, and then went back and was said to be asymptomatic. Well, it turns out she wasn't asymptomatic. So when she infected other people, it turned out she actually had either prodromal disease just before she was becoming very ill, or she was actually ill. The average incubation period is 5 days, as I already said. And the clinical symptoms, I think, are well known now. Fever is in 83 to 98% of people, but this is important because not everyone has a fever, not everyone has a cough. And we know, as we know more and more about asymptomatic people, there's going to be more people identified. We just have heard in the last week about people who are having anosmia being infected with the virus. So these are people who are completely asymptomatic but have lost their sense of smell. And how this is going to relate to the infection, whether these people become symptomatic, whether sense of smells return completely, which I think they will, are something that remain to be determined. Myalgia and fatigue occur in 11 to 44%, and shortness of breath in 31. Some patients have diarrhea or productive sputum. Generally, the absence of coryza or a runny nose is not considered part of this disease, but I wouldn't consider its absence as a reason to not think someone has it, because people can be co-infected with something that gives those symptoms. And of the hospitalized patients, many of them don't do well, end up with ARDS, and some end up with secondary infections. So, and this is an older slide. This is from 6 weeks ago or 5 weeks ago. Of these cases, these numbers I think are still true. 81% of people have mild symptoms, 14% have severe symptoms, and 5% are critically ill. And these are the people who are overwhelming the healthcare system, because if you take that number and you multiply it by the population of a city or a country, you can see you have huge numbers of people who are critically ill. That's one of why people's goal is either to mitigate or actually suppress transmission. Because if we end up in a situation like it has occurred in Italy, healthcare facilities are overwhelmed, healthcare workers get disproportionately infected. And we also know that the case fatality rate is higher in people with comorbidities and in the age. For people over 80, there's the last number I saw is a 15 to 20% mortality. And this is the main reason to encourage young people to not get sick, because if they go home and get their 80-year-old grandmother sick, then he or she will, or grandfather, he or she will have a 15 to 20% chance of succumbing to the infection. So based on, I've already mentioned this a little bit, respiratory droplets and close contact are the main way the virus spreads. That's why we recommend that people stay 3 to 6 feet away from each other to diminish possible transmission, even with somebody who you don't think is transmitted, particularly with these asymptomatic people who I don't think readily transmit. We really just have to follow this as a general rule because we just don't know. And certainly having direct contact with infection secretions will enhance transmission. And SARS-CoV-2 has also been detected in stool and urine, but the clinical significance is really unknown at this point. So routine environmental cleaning and disinfection is appropriate. But as I mentioned, if somebody coughed on a doorknob 2 days ago, I don't know if that virus will actually or is still viable enough to even cause an infection in somebody who touches that door handle. But the better part of valor here is to make sure you have routine of cleaning and disinfection. So drugs. So what do we do here? This has been a huge issue because, of course, we want to develop antiviral drugs that are effective. The only one that I think has theoretical basis for being effective is remdesivir. It has worked in studies in experimentally infected animals with SARS and MERS. And it's something that inhibits a virus drug. It's a drug that inhibits the viral polymerase. So resistance doesn't readily occur. One of the things about this is that if resistance does occur, the virus is attenuated, so it doesn't grow as fast in people or animals. Presumably, we just know about animals. The other thing about this is this drug must be given early during the infection. Most of the therapies that people are even trying you have no reason to think will work if not given early during the infection. So the things to consider with remdesivir that make it less than perfect is that it's intravenous. It's effective, as I said, only during the early stages. In later stages, a virus may be cleared by treatment without affecting clinical outcomes. And then a question is, who should you give it to? If 85% of people just have mild disease, it would not be useful to give them an intravenous drug. Whether we need a biomarker, I think that's probably the answer. This was tested in Ebola and was found to not be as useful as 2 competing antibody cocktails. Hydroxychloroquine is one that's been bandied about now as being very being useful. Chloroquine has been used in the past against murine coronavirus infections without actually useful effects. This is the idea behind chloroquine are twofold. One is it's based on data that chloroquine can inhibit entry of the virus into cells, and it also has anti-inflammatory effects. Hydroxychloroquine is 8 times more active than chloroquine. And while virus entry is inhibited by chloroquine or hydroxychloroquine, the drugs only inhibit one route of entry into cells. So the virus is very clever, has lots of ways to get into cells. The one that it likes to use most is via a different pathway that's inhibited by a drug called capacities. And that drug is available only in Japan, not anywhere else. We don't know how well it would work in the human infection, but that at least works at the other pathway of entry into cells. And as with anything else, this drug would have to be given early in infection to have any effect. Right now, we don't know at all that it has any effect. I doubt it will in the virus entry. Maybe it has an anti-inflammatory effect. This is not really known. And I don't know that people would choose to take hydroxychloroquine or chloroquine for its anti-inflammatory effects. There's lots of other drugs that have anti-inflammatory effects. And as I think we know, hydroxychloroquine is toxic if given at high concentrations. So hot weather, will this make the virus go away? Many respiratory viruses diminish when weather turns hot. That's not weather. That should be real weather. Influenza A is the best example. However, warm places like Singapore, Hong Kong, southern China have ongoing COVID-19 epidemics, and the virus does not seem to be hindered there. Influenza seems to do just fine in these places as well. So we hope that the virus will disappear either completely or partly when the weather turns warmer, but this is not known. And of course, if it does, what this will do is this may give us a chance to actually prepare for the next round of the virus, which seems like a good possibility, unless so many people are asymptomatically infected that we have herd immunity against the virus. But like the influenza outbreak in 1918, there's a good chance the virus will come back in 1 or 2 additional waves. So this is one of the goals of what we're doing here with mitigation or suppression. You try to delay this epidemic peak. Problem with this peak is once you have it, maybe everybody's protected, but there'll be so many deaths and the healthcare systems will be so overwhelmed. As you can see here, this is the line for healthcare capacity. So we want to spread it out over a longer period of time, which will mean that it'll last longer, but that fewer people will die and healthcare facilities will be able to handle patients. And so this is something that just came out about persistence of coronaviruses on surfaces. And some of these numbers are true, but so for example, here's wood is 4 days, glass is 4 days. The way this is usually done is with putting large amounts of virus on a surface and then asking, is it still there 4 days later? The amount is usually much lower than the amount that's put on experimentally is usually much higher than occurs in the natural infection. And the amount of virus goes way down. But if you start with a large amount on some of these surfaces, you can still detect some. So it wouldn't change what I think about cleaning surfaces, being careful about it and doing and using bleach or 70% ethanol to clean surfaces or other compounds. But it may mean that this risk is really relatively minor to respiratory spread via large droplets. And with that, I'm going to stop.
Thank you so much, Dr. Perlman, for a very insightful talk. I think there must be questions from participants in the meeting. We'll wait for that.
The first question is, do we have any data on whether reinfection is a possibility?
So we don't really have data on that now. Based on previous studies with MERS or SARS, I would suspect that there's not going to be reinfection at early times in the next few months after infection, but I really don't know what happens over the long term. That's why we need to know more about the immunity to this virus, and it's particularly important if we're developing vaccines.
False negativity of PCR testing?
Well, this is always a hard question. So usually if the test is done well, PCR testing is exquisitely sensitive. So that shouldn't be an issue. There certainly could be false positivity if the virus isn't there. So in some patients, it seems like the virus may have been in the upper respiratory tract and then may track down to the lungs and no longer be in the upper respiratory tract, and they may come back up. So the test is very sensitive when the virus is there. The issue may be that the virus is not there.
Dr. Perlman, can you stop screen sharing?
Oh, yes. Let me see how to do that.
Next question is, my understanding is those who are ill enough to receive ICU admission and ventilation have very poor outcomes. Do you know the answer to that question?
That's true. I think that they're certainly the group that died from the infection. Have I stopped sharing my screen yet? No?
Not yet.
Okay, next question is, can you comment on age-related susceptibility?
Oh, that worked. Thank you.
Yes, sure. Well, so there is age-dependent susceptibility, as we talked about. If you're over 80, there's a higher mortality. If you're over 70, it's much higher than people who are under 70. So we think that people from 60 to 80 are at higher, 60 and over, a higher risk, particularly 70 or over. Some universities in the United States are sending everybody who's over 70 home and telling them they can't work anymore at the university. So there's definitely a higher risk. And what's even more remarkable than the age having higher risk is that children are actually pretty resistant to the infection. They get infected at the same rate, but they don't develop severe disease. And this is something we'd like to understand. This was also true in SARS and MERS. So children seem to do much better with these infections. And whether it has to do with the immune response, the milieu of the lung because we know that older people are exposed to more, as you get, every year you're exposed to more and more environmental antigens, and whether this matters or not is something that we are still investigating.
Can we blindly restrict patients who are already ready for allowing a natural death from being on ventilators? This is a question, I believe, for Raj.
Uh, let me put it this way. If I have written my advance directive that whatever be the disease process at my age, I would not, in the event of a serious illness, like to be put on artificial support, life support. Uh, this question comes from Dr. Atul. Atul really is asking, okay, is that, Atul, please correct me if I am wrong. You are asking if I have written my advance directive and you had already decided that if I had advanced cancer, you wouldn't put me on a ventilator. When it is corona, would you change? I mean, that's left to me, isn't it? If I have written the advance directive and if I am competent to take the decision, it's up to me. And if I am not competent, it's up to my family to take that decision, not the treating doctor. Just because it's corona, you can't impose that ventilator on me.
Thank you, Raj. Sorry, is corona prevalence low in malaria endemic areas? Stanley?
I would suspect testing is low rather than the virus itself.
Okay, thank you. The questions are coming fast and furious. Is there any immune therapy that has a value to prevent or treat?
Yeah, I think that if you give either convalescent sera with high titers to the virus, or you give antibodies to the virus at early times, either when people have mild disease or when they're just starting to get more severe disease, I think you might help prevent more severe disease. But it has to be given so early, and it's very hard to know who those patients are because they're indistinguishable from the people who get some disease but recover on their own.
And that's not currently available, correct?
That's not available anywhere. I mean, the people are getting it. The antibodies are not available. The convalescent plasma people are starting to get available.
Okay.
Dr. Perlman, can you help demystify clinical testing for this virus?
Can you what?
Help us understand the clinical testing. How do you test for the virus?
Oh, so the testing, if
system.
someone has the virus, that's where you have to do this test for genomic RNA, this RT-PCR test, which is very, very sensitive. And that's the best way to diagnose it. We don't have good tests yet for serology or antibodies to the virus to show that somebody had it in the past. Those tests are being developed at many, many places throughout the world, but we don't have those yet. In the United States, we had a testing problem because we knew that this test was useful, but we didn't have enough reagents and we didn't have enough testing kits, and we have other components that were deficient. I don't know how India is doing with that, but it's a relatively simple test, but you have to be prepared to have large amounts of testing kits available.
Okay, we're going to do one more question, recognizing that things have, we were delayed by something called Zoom bombers. Didn't know that was a thing until this morning. There are reports that suggest, excuse me, let me just interrupt myself to say, we will take all of these questions and answer them. If you've provided your email, we'll provide you with the recording and answers to these questions. There are reports suggesting that coronavirus strain in India is much milder than the one in other countries, and that's one of the reasons for low infectivity in India. Any evidence for this? Do you agree or disagree?
So far, there's no evidence that the virus is actually any different anywhere. This virus has changed remarkably little since it was first diagnosed there. These kinds of viruses like to mutate a bit, and they do change all the time, but what matters is a change that makes the virus either easier to transmit or cause more severe disease in a person who's infected with it. But there's no evidence that that's occurring. We're just seeing the kind of noise, as it were, that RNA viruses always do. So no evidence, and there's no evidence that in India that it's actually, maybe there's evidence that it's milder, but it may be because maybe there's not that many cases. It would be great if it were milder in India. And also the other thing is the population in India tends to be younger than the population in the US or Europe. So this may also contribute to less severe disease and more asymptomatic infection. So I would think those issues are more important than the virus itself.
I'm sorry.
Can I ask two very important questions, related questions from India? And the first one is, how much protection should the health workers take while treating a general public? And any recommendations of making the existing supply of PPE last longer?
Yeah, so the first one is, I think that people have to use the same precautions that they should always be using when there's a possibility of infectious disease being spread. So both standard precautions and universal precautions are important. You don't need to think about aerosolization unless a procedure is being done and you suspect someone has COVID-19. So that's not going to change. But when you see any patient, you should be wearing a gown and gloves and especially protect yourself from infection by that patient. So COVID-19 notches things up one step, but it's still just the same precautions. And of course, if you know you have someone who has COVID-19, you have to put on additional precautions just to make sure if you're doing tracheal aspirations or obtaining sputum that you're not aerosolizing the patient's virus. The second thing, in reusing PPE, this is something that a week ago we never even thought about, but everywhere in the world they're running out of masks and face shields. So there's now protocols for reusing them. The masks are even, particularly N95s are being reused. You can't, and we know a lot about this, so we know the UV light at the right level might kill the virus and might be useful, but the problem with UV light is that it may not kill a virus that's embedded into the masks. And if you do too much UV light, you probably destroy the integrity of the virus, of the mask. You can't use solvents on it because that'll destroy the mask, but you might be able to use like bleach wipes to wipe it down. I think that those are safe enough to do it. But there's actually a big discussion on the internet about this, and I'm not sure exactly where it stands now. There's certainly things that'll destroy a mask's integrity that you don't want to do. Some people are recommending autoclaving or putting it into wet heat and heating it for heating the mask for a certain amount of time. We know that the virus will be killed if you heat it to 60 or 65 degrees for about 30 minutes. So you have to figure out if you can do that and not destroy the integrity of your mask.
I just want to make sure that we clarify, for a suspected or a real COVID patient or documented COVID patient, you want mask, gloves, and a surgical mask. If there's any possibility of aerosolization, you want an N95. For regular patients who do not have symptoms, hand washing and distancing is the way we're handling it at our hospital. And hand washing is not what we usually used to do for hand washing. It is more like a surgical scrub than the hand washing that we're, I think, used to. Alcohol rub or 2 minutes of soap and water.
We have a lot more questions, but in the interest of time, I think we can wind up. We will get this recording to all of you who have given us your email. We'll share this on social media. For some of those questions that you have written, we'll share it with Dr. Perlman and see if we can get a response from him, provided he has a little bit of a time. We really appreciate Dr. Perlman and Dr. Rajagopal. Both of us are global leaders in what they're doing, for sparing their valuable time and patiently, waiting with us while we were trying to clear up all the Zoom inexperience that we had in hosting this meeting. Thank you all participants for joining us. Have a good day wherever you are, and God bless.
And wash your hands.